بسم الله الرحمن الرحيم. Assalamu alaikum. Welcome in this new meeting of continuous medical education meetings of Egyptian Society of Nephrology and Transplantation. Today we have new two of our young generations, very promising generations in the field of nephrology in Egypt, that we have met many times in our conferences, in our meetings, in our CME activities, and I think they are both well known too. I'm pleased today to have them as speakers, as one of rising stars in the nephrology, and starting their way and on the way and their careers as speakers in the national and international conferences. Our first speaker is Professor Nashwa Azooz, Associate Professor of Internal Medicine and Nephrology at Azooz University. I met her about 5 years ago when she was starting her career as a lecturer in Azooz, and was going very step by step in a very promising way. And now she's starting the second degree as associate professor, and I enjoyed many of her lectures. Today, she will speak about one of the major uremic complications that we all met in our clinical practice, which is uremic neuropathy. The second speaker is my young friend and my dear friend, Moatasem ElSayed, Dr. Moatasem ElSayed from Mansoura Nephrology, Urology and Transplantation Center. Moatasem is the student of all of our professors in Mansoura Nephrology and Urology Centers, Transplantation Center. He is the student of Professor Muhammad Subh and Hussein Shaisha, rahmatullahi alayh, and many of our colleagues, great professors, and he is one of the great young generations as expected to be the students of them. Moatasem gained his MD degree recently, few months ago, and he is my dear friend, and really I consider him my young brother, and very helpful to me in these activities of CME activities of Egyptian Society of Nephrology and Transplantation, and I think you have met him as a coordinator of many meetings. Today, Moatasem will speak in the second lecture about the bleeding complications of uremia. Let me start this very interesting meeting, and we expect to have many informations and very hot discussions, and I would like to welcome all our attending professors of Egyptian Society of Nephrology and Transplantation and all our attendees in this new night and this new session of CME meetings. First speaker is Professor Nashwa Azooz to start by uremic neuropathy. Please, Professor Nashwa, start your lecture. uremic neuropathy.
السلام عليكم دكتور ياسر، ازي حضرتك؟ شكرا افضل حضرتك يا فندم على البرزنتيشن والانترودكشن بتاعت حضرتك، والف شكر على الدعوه الكريمه. النهارده ان شاء الله هقدم محاضره من الموضوعات المهمه جدا ومن الموضوعات اللي بتقابلنا كتير في المجال النفرولوجي. Today introduction what is the uremic neuropathy, epidemiology, prevalence among the neuropathies, pathogenesis and causes, diagnosis, treatment, comparison with other types of neuropathies, and special topics, and the last conclusion. At first, definition of the chronic kidney disease. Chronic kidney disease is defined as structural or functional abnormality for more than 3 months, depending on the cause, GFR and albuminuria. And this is the diagram of KDIGO guideline 2022 of the chronic kidney disease. Uremic polyneuropathy is among of the patients, Uremic polyneuropathy is a common among the dialyzed patient with end-stage renal disease, generally develop only with a patient significantly reduced GFR. However, patient already being adequately dialyzed may have polyneuropathy and often to be subclinical or detected by electrophysiological studies. Definition of uremic neuropathy. Peripheral neuropathy, it is an disorder that affects the cell body axon myelin of the motor or peripheral sensory neuron. It is common to be distal, symmetrical, mixed sensory motor affection. It typically involve the lower extremities more than the upper extremities, and the sensory symptoms typically precede the motor symptoms. Motor involvement usually indicate onset disease. Some consider restless leg syndrome as a part of clinical spectrum of the uremic polyneuropathy. It is affected about 60 to 100% of patients who are submitted to dialysis due to chronic kidney disease. The overall prevalence of the peripheral neuropathy is 2.4%. And it can be classified according to the nerve type, maybe sensory, autonomic, motor, or according to course, acute or chronic, or to the site of nerve affection, axonal, neuropathological, or demyelinating affection. This study done to affect the incidence of the polyneuropathy among the uremic patient undergoing hemodialysis. It is a cross-sectional study done on 215 patients with end-stage renal disease, and this is have a neurophysiological assessment for uremic neuropathy regardless the clinical finding. The incidence was 95% has a confident significance, and the duration of the hemodialysis was the blue line. It is about 5 years. So the uremic neuropathy was a distribution of the uremic neuropathy between these patients was 63.7% positive uremic neuropathy against 36.3% was negative for uremic polyneuropathy. According to the pathology and pathogenesis, uremic polyneuropathy, it is a distal, symmetrical, mixed sensory motor neuropathy characterized by demyelination and axonal degeneration. According to the axonal degeneration, it is appear primary, then segmental demyelination occur. These changes most severe distally with long axes are affected at first, then the peripheral nerves involvement with demyelination of the posterior column occur. The cause of the uremic polyneuropathy is unknown, but there is multiple factors are suggested. May be natural deficiencies of the toxins, toxic neuropathies, as deficiency of the thiamine, zinc, biotin, decreased transketolase activity, or accumulation of the organic waste products, including el-parathermone, el-phenol, el-beta-2 microglobulin, and other middle molecule uremic toxins. This study done to show the effect of the indoxyl sulfate and oxidative stress on the severity of the peripheral nerve dysfunction in the patient with chronic kidney disease. This study done in two groups. One group was diabetic and the other group non-diabetic. This group done the clinical neuropathy score with nerve conduction study and laboratory test to assess uremic toxins, and the results was there is a sensory motor neuropathy was more in the diabetic more than the non-diabetic, and the sensory neuropathy non-significant between a diabetic and the non-diabetic. And there is a positive correlation between the indoxyl sulfate as uremic toxins and the amplitude score, with positive correlation with the age and albumin-creatinine ratio. Another study is done to show the relationship of electrophysiological study of the uremic polyneuropathy and the uremic toxins in the CKD patient. And the conclusion was the peripheral neuropathy is common in chronic kidney disease patient, causing significant morbidity at very early stage, and through blood urea nitrogen and serum create are dialyzable toxins, and it is correlates significantly with neuropathy severity and can be guide marker for optimization of the dialysis therapy. The effect of the potassium in the uremic neuropathy, there is a lot of studies was found there is a nerve excitability demonstrate alternation in the membrane potential, and have suggested that hyperkalemic depolarization may underlie the development of uremic neuropathy rather than the middle molecules. Symptomatology, sensory and motor changes was present. It is very typically present as a slowly progressing sensory motor axonal neuropathy, which advances proximally and starting from the lower limb may spread to the upper limb. Early symptoms are parathesia, paradoxical heat sensation, restless leg syndrome, and increased pain sensation and cramps. Long-term symptoms was weakness, impaired deep tendon reflexes, imbalance, numbness, and atrophy of the lower limbs. This picture appears the different symptoms of sensory affection which affect the neuropathy. The diagnosis of the uremic neuropathy gold standard diagnosis is a nerve conduction study. There is a complementary methods that include neurological assessment as quantitative sensory loss touch and vibratory perception threshold are more sensitive to evaluate their progression or recovery of the uremic neuropathy than the conduction velocity. Distal axon biopsy to assess the number of functional axons in nerve according to changes in amplitude of the muscle response and sensory nerve action potential. Velocity conduction to assess myelination of the nerve fiber and its density. And the psychological evaluation, we need to add due to a lot of symptoms is subjective, and this is a limitation of the neurological test. A limitation of the test, number one, it is remain asymptomatic for a long time, and the only cause symptoms when severe damage is occur. Number two, it is a subjective. Number three, some patients suffer from thermal sensitivity impairment before sensory and motor damage. Treatment of the uremic neuropathy, the role of the hemodialysis improve the uremic neuropathy, but the definitive treatment is a renal transplantation. There is a superior results for conventional hemodialysis over the peritoneal dialysis, and the increase the dose of the dialysis improving the uremic neuropathy. Hemodiafiltration is another therapeutic technique, has a benefit for motor nerve excitability, and the renal transplant, it is a definitive treatment to remove the symptoms of the uremic neuropathy and stop its progression. This study done on a randomized controlled trial of the impact of the hemodiafiltration on the uremic neuropathy, اللي هي finance study. It is done between two groups of chronic kidney disease with uremic neuropathy, one group on hemodialysis and with a high flux, and the other group on the hemodiafiltration. And the strength point at this study was number one, the primary cause of the uremic neuropathy is middle molecular weight uremic toxins, especially beta-2 macroglobulin, which more cleared by the hemodiafiltration. The reduction in the prevalence of the moderate to severe neuropathy from 80% in a high flux group versus 48% in hemodiafiltration group. And there is a pre-dialysis hyperkalemia caused peripheral nerve depolarization, which more common مع high flux hemofiltration. And this is another study done to rapid reversal of uremic neuropathy following the renal transplant in adolescents. And this result done in adolescent and children. And the uremic, the two groups before and after the dialysis, and the end result after the renal dialysis, there is a definitive improvement of the uremic neuropathy. In the children, the nerve conduction is altered likewise in adults, and show the mean peroneal motor nerve conduction velocity significantly decreased for children with mild renal failure, and the ulnar mean nerve conduction was significantly decreased when the serum creat was 9 milli per deciliter. After renal transplant, by 1 year, the ulnar nerve conduction is completely improved, and the peroneal improved after 3 years of renal transplantation. The periodic measurement of the nerve conduction velocity is not useful to follow uremic neuropathy in children undergoing chronic hemodialysis. There is another study done to use the ether therapy in uremic neuropathy in the hemodialysis patient. And the conclusion was the use of the ether therapy may improve the uremic neuropathy in patients with newly diagnosed end-stage renal disease who have been started in hemodialysis, especially in the subclinical neuropathy. The other study done to use the folic acid and vitamin B12 in chronic kidney disease. And this study done due to the effect of the hyperhomocystinemia and folic acid deficiency and vitamin B12 deficiency, which occur with the chronic kidney disease. So when with use the folic acid and vitamin B12 has a cardiovascular and mortality risk improvement, not for treatment for the uremic neuropathy, but it has a cardiovascular risk improvement. Another study done to the water-soluble vitamins in low GFR, and the results was improving of the pain, neuropathic pain, due to the effect of the vitamin D in remyelination. There is a special entity of the uremic neuropathies, a restless leg syndrome. Restless leg syndrome, it is a sleep disorder, can cause intense severe urge to move the legs or arm or body, along other sensation describing the creeping or tucking or throbbing pain or itching or aching pain. This sensation usually occur when lying down in bed or sitting for a long time. Restless leg syndrome has a lot of causes, including uremic neuropathy. The causes as low level of iron, uremia, hypothyroidism, depression, fibromyalgia, Parkinsonism, rheumatoid arthritis, and peripheral neuropathy. The other important topic for neuropathies, uremic optic neuropathy, which cause sudden vision deterioration and focal edema of the optic nerve, and it is disorder detected by ophthalmoscope by a swelling of the optic nerve heads and the blaring margin of the optic disc. When the patient has advanced chronic kidney disease present with vision deterioration, and the cause is unknown, but it is related to the accumulation of the dialyzable toxins metabolite, the treatment is a hemodialysis and combination with steroid. This diagram appear the comparison with other neuropathies. There is a lot of types of neuropathies as diabetic neuropathy, and it is the most common type of neuropathy, mainly sensory affection, stuck and the glove hypothesia, and its role in treatment as a lifestyle modification and control, glycemic control. Another type as alcoholic neuropathy, and it has painful paresthesia, motor affection, gait impairment, and the treatment to cessation of the alcohol and thiamine treatment, but not effective. Chronic inflammatory neuropathy has a weakness in the symmetrical and characteristic to be proximal and distal with a sensory affection. And lastly, infectious neuropathy as virus C or HIV, it is characterized by acute ascending motor neuropathy associated with Guillain-Barré syndrome. My conclusion is uremic neuropathy is a prevalent condition affecting about 60 to 100% of patients who suffer from chronic kidney disease, depending on the classification criteria. The exact mechanism is demyelinating process lead to axonal degeneration and loss. However, the electrolytes and mostly potassium has an important role in the pathophysiology of the uremic neuropathy. The clinical presentation of the uremic neuropathy are broad and vary, essentially to detect the early changes in the order to diagnose the uremic neuropathy and to avoid its progression. The earlier signs and symptoms of the uremic neuropathy are detected. The earlier uremic neuropathy is diagnosed and the better outcome. The treatment of the uremic neuropathy is the hemodialysis, but the definitive treatment is the renal transplant. And thank you. Sorry.
Thank you. Thank you, Professor. Thank you, Professor Nashwa,
Thank you
for this highly comprehensive talk. She spoke about neuropathy in a very comprehensive and concise way, how the pathogenesis and clinical picture. And an important part of the clinical picture is how much difference between it and the other neuropathies. Importance of dialysis and the methods of hemodialysis needed and the effect of various types of methods of hemodialysis. Also the effect of renal transplantation. Also, she mentioned some of the new therapies of this important complication, neuropathy. And was a very interesting talk, and I can see many questions of the chat and comments. Professor Hisham ElSayed.
Thank you, Professor Nashwa. It's very comprehensive and educational, very good educational material that everyone should know the basics of differences between uremic neuropathy and the others. I usually say, it's my word, that the difference between retention uremic solids and its toxicity, the bridging is inflammation.
Yes.
So So if you have a retention solutes, may not have the same consequences like a patient with the same level of the same toxin without inflammation. We can give an example. If the patient pre-dialysis beta-2 microglobulin is around 30,000, for example, some of them go to beta-2 microglobulin amyloidosis and deposition, and some others don't. The difference is inflammation. For your uremic neuropathy, the third most common indication for hemodiafiltration, starting number 1 of hemodynamic instability, number 2 beta-2 microglobulin amyloidosis, and the third one is neuropathy. And all of them are carried out by inflammatory cytokines removal. So I like that you stress on the technique of hemodialysis and hemodiafiltration for improvement, as well for preventive stress. I am always satisfied by your material, and I think all the colleagues in the chat are asking, you will respond soon, but it's very good material just to have read and communicating that information with others. Thank you very much, Nashwa. I really enjoyed.
Thank you.
Thank you. Thank you, Professor Hisham, and thank you, Professor Nashwa. We have many questions on the chat, but I will not go through except after the second lecture to hear from Moatasem. But excuse me to ask a question before we start the second lecture. Do you said that renal transplantation is a definitive treatment? Is it really definitive, or should be done before establishing this complication? I met many people with neuropathy and did renal transplantation, and unfortunately the neuropathy did not improve by transplantation. What's your comment on this point? Is it a definitive treatment really and reversing the complication?
I found a lot of studies about the renal transplantation have improvement of the uremic neuropathy after transplantation, and it is the only modality to have improvement in the uremic neuropathy. A lot of studies done. A lot of studies.
And resulted in short improvement, total improvement of neuropathy.
Yes, total improvement.
But this I really astonished that I did not make that a lot of studies in my clinical practice. Okay, maybe an observational practice for me, but the studies say that it leads to improvement. Please keep with us to the end of the session. And we will start the second one. Let me go to the second lecture today. Dr. Moatasem ElSayed, my dear friend, Dr. Moatasem MD in, as I said, in kidney urology and nephrology and transplantation center. And he is, I think, the pioneer students of our pioneer professors and colleagues. He will speak to us today about bleeding tendency in uremic patients. He will continue uremic complications by addressing bleeding tendency. Please, Dr. Moatasem.
Thank you, Professor Yasser, for these nice words. And actually, it means a lot to me. Thank you so much. And thanks for offering me this opportunity to be here with my professors and colleagues in ESNT CME platform. Today, I'm going to talk about bleeding tendency in uremic patients, and I hope that you enjoy it, inshallah. The first to describe this association between bleeding tendency and uremia was Morgagni in the middle of the 18th century. Also, David Reisman described this association 100 years ago. And in this recent study, which followed more than 10,000 patients with CKD had 1.5-fold more increased risk of bleeding as compared with patients without CKD. And this risk of bleeding increased up to 3.5-fold, with more decrease of GFR, less than 45 ml per minute, and with adding another risk factor, which was albuminuria. But actually, CKD patients present a dilemma in that they have both sides of the coin. They are simultaneously prothrombotic and hemorrhagic. And the prothrombotic tendency can be due to increase in their coagulation factors, increase in antifibrinolytic proteins, hyperlipidemia, and the changes in platelet membranes, which make them pro-aggregatory. This is our agenda for today, and through our talk, we will try to cover these items. We will start by pathogenesis. This is a normal mechanism of the mechanism of normal hemostasis. After injury occurred to the vessel wall, there are two complementary arms. Platelet activation, which starts by platelet recruitment to the site of injury, followed by platelet adhesion and aggregation until formation of the platelet plug. And the other complementary pathway, which is the coagulation pathway, either external or internal, which ends by formation of fibrin and fibrin clot. And as the prothrombin and EBTT are more or less normal in uremic patients, so the most acceptable and the most proposed mechanism for this impaired hemostasis in CKD patients is the platelet dysfunction. And this platelet dysfunction can be due to impaired platelet vessel wall interaction or impaired intrinsic platelet abnormalities, together with another risk factors like anemia, dialysis, and medications, and we will discuss them. What about impaired platelet vessel wall interaction? It can occur due to dysfunction of von Willebrand factor. Normally, von Willebrand factor bind to glycoprotein receptors, causing production of thromboxane, A2, and EDB, which are important factors for platelet activation and adhesions. But in uremic patients, there is a dysfunctional von Willebrand factor, which means there is either decreased binding affinity for glycoprotein receptors or reduced expression of glycoprotein receptors on platelets. What is the role of nitric oxide? Nitric oxide normally causes vasodilatation and inhibition of platelet aggregation and adhesion, and it is increased in uremic patients. Uremic patients have high levels of prostaglandin I2 and nitric oxide, secondary to uremic toxins, mainly L-arginine, which act as a precursor for formation of nitric oxide. The role of cyclic AMP, uremic patients have higher levels of cyclic AMP, secondary to persistent higher levels of prostaglandin I2. And this high level of cyclic AMP will decrease the level of thromboxane A2 and EDB and so cause platelet inactivation. Again, it is similar to cyclic GMP. Again, cyclic GMP will be higher in uremic patients, secondary to higher level of nitric oxide. As we said before, it is increased due to uremic toxins, mainly L-arginine. And high levels of cyclic GMP will cause platelet inactivation. The second proposed mechanism is intrinsic platelet abnormalities. It causes a disease called the platelet storage pool disorder, which means normally platelets have two types of granules, either dense or delta granules and alpha granules. Both of them secrete many molecules which are important for platelet activation and adhesions. But in this disease, there is a defect in either number of these granules or defect in their secretions in bloodstream, which will lead to platelet inactivation. And of course, it is a functional platelet disorder, meaning that platelet count will remain normal. Okay, so to conclude, platelet dysfunction may be either due to defect in platelet vessel wall interaction and adhesion, or defect in platelet aggregation, or defect in platelet secretion of their contents into the bloodstream, as we said before. The third mechanism is anemia. Anemia can affect or can increase bleeding tendency, and a hematocrit more than 30% is thought to improve platelet binding to the vessel wall by a rheologic mechanism, which means when RBCs occupy a greater portion of the vessel lumen, when they are central in position, platelets will be pushed toward the vessel wall at the endothelial surface, and this close proximity will allow the platelet to adhere more to the endothelium more efficiently. But in cases of anemia or low hematocrit, platelets will be pushed away from the endothelial surface. Also anemia. In anemia, there is a decreased hematocrit level, which is translated into increased in plasma volume and relative thrombocytopenia in relation to the plasma volume. RBCs secrete important factors which are activate platelets. This will be deficient in anemia, and hemoglobin itself act as a scavenger it has high affinity for nitric oxide. So in cases of anemia, there will be higher level of nitric oxide and so higher level of cyclic GMP and so platelet inactivation as we discussed before. What about dialysis? Normal uremic patients retain more than 92 known uremic toxins. Of them, L-arginine will induce nitric oxide synthesis, and guanidine succinic acid and phenolic acid will inhibit ADP-induced platelet aggregation. So we can say that dialysis may improve hemostasis by removing these uremic toxins. But can dialysis itself be a risk factor for inducing bleeding in uremic patients? Actually, in this study, which followed 1,745 patients, of them 70% received hemodialysis, in comparison to 30% of had peritoneal dialysis. Bleeding risk for hemodialysis patients was higher by 1.5-fold in hemodialysis than BD. And this can be attributed to the artificial surface of the dialyzer itself and the blood tubing, which can cause platelet activation and degranulation, using heparin during hemodialysis, intermittent puncture of the vascular axis, the removal of important compounds which are important for coagulation process in uremic patients, and using less biocompatible membranes which can cause complement activation and the platelet activation and degranulation. What about peritoneal dialysis? Actually, peritoneal dialysis may be more effective in reducing risk of hemorrhage and bleeding than hemodialysis due to relatively high hematocrites in BD patients, absence of platelet activation by artificial surfaces and membranes, the lack of systemic heparinization and use of heparin, and better clearance of middle molecules in BD. And we can even say that BD has a more pro-aggregatory effect than hemodialysis, because in vitro aggregation of platelets from patients undergoing BD was superior to that of patients receiving hemodialysis. But can BD cause or contribute to bleeding risk? In this case report, which was repeated around 6 or 7 times in the literature, intraperitoneal vancomycin caused induced immune thrombocytopenia. Normal systemic absorption of vancomycin after intraperitoneal administration is around 50%, but this can increase up to 90% when there is peritonitis, and the treatment of this case is mainly by stopping of the drug. What about the vascular axis? Would it differ if I had AV graft or versus an AV fistula? In this study, which is an observational cohort study, which followed more than 17,000 patients with AV graft in comparison to more than 60,000 patients with AV fistula, AV graft was associated with increased risk of venous thromboembolism and potentially a small increased risk of cardiovascular death as compared to AV fistula. What about major bleeding? As we can see, there was also a small, but not significant, a small increased risk of major bleeding in the AV graft group. What about anticoagulation? It was thought that low molecular weight heparin was proposed to cause less bleeding and less thrombocytopenia than heparin. But in this meta-analysis of randomized trials, which was published in 2004, they were comparable, either low molecular weight heparin or using unfractionated heparin. And in this more recent systematic review and meta-analysis, which was published in 2017, also there was no statistical difference between low molecular weight heparin and unfractionated heparin in inducing bleeding. What about dialysis-induced thrombocytopenia? The causes of dialysis-induced thrombocytopenia can be due to pseudo-thrombocytopenia, HIT, secondary antiphospholipid, the dialyzer membrane itself, infections or medications. The first, pseudo-thrombocytopenia, it is suspected when asymptomatic thrombocytopenia is found in a hemodialysis patient. It mainly occurs due to using anticoagulant or EDTA for lab testing, which cause clumping of platelets. The second cause is heparin-induced thrombocytopenia, which cause more common with unfractionated heparin than low molecular weight heparin, and it is characterized by thrombocytopenia and thrombosis. And as we know, it can be divided into 2 types: type 1, which is mild self-limited type, and type 2, which is immune-mediated and is characterized by presence of autoantibodies against heparin platelet factor complex, platelet factor 4 complex. And according to the 40 scoring system, which include thrombocytopenia, timing of the decrease of platelet count, presence or absence of thrombosis, and presence or absence of other causes of thrombocytopenia, we can categorize patients to Azooz with low, intermediate, or high probability risk of having HIT. And the treatment of this case is mainly by discontinuation of heparin, even heparin, locking the catheters with heparin. And we should avoid and stop warfarin, even we can reverse it by vitamin K to restore protein C and S. And by using direct oral anticoagulant, of them, argatropan is preferred if the patient doesn't have severe renal failure. It has a short half-life. It is given as continuous infusion. And we should take care of INR because this drug can profoundly increase INR. And a specific protocol must be followed when bridging back to warfarin. Bevacizumab is an FDA approved for using in patients undergoing PCI with or without HIT. Fondaparinux is another alternative, which is given once daily, sub-Q, and we should be careful as it is contraindicated with creatinine clearance less than 30 ml per minute. Secondary antiphospholipid antibodies can be secondary positive in long cases of hemodialysis patients, and it can be present in a rate between 11 to 37%. Being antiphospholipid positive should be suspected in hemodialysis patients with repeated thrombosis, with or without thrombocytopenia. With we should be careful when giving them anticoagulation or antithrombotic therapy, especially if platelets decreased below 100,000. What about the dialyzer itself? Dialyzer can affect platelets due to its biocompatibility, whether it is high or low biocompatible, method of its sterilization, and allergic reactions that can occur to the dialyzer. While older membranes, which were very bioincompatible, increased complement activation and platelet activation and leukocyte sequestration in the lung. Actually, newer membranes, platelet activation seemed to be reduced with them. However, still, there is a substantial degree of platelet activation can still occur with these synthetic membranes, but of course it is more and more less than the older ones. And it is mainly maybe due to a type of sterilization, electron beam sterilization. And in this case report, there was a thrombocytopenia induced by polysulfone membrane, and risk factors for this case was type of sterilization. And this was treated by substitution with another membrane with a different composition from another manufacturer, or another membrane with another type of sterilization like gamma array. And some cases, few cases may respond to using cellulose dialyzer. What about dialyzer reuse? Actually, it is discouraged nowadays because of potential for contamination and chemical exposure to staff and patients. But in this case report, dialyzer use was a solution for this thrombocytopenia. Of course, we can't generalize this finding because it is just a case report. But anyway, dialyzer use, it reduced the exposure to industrial residual chemicals used in these membranes, in the manufacturing process of these membranes, and it increased dialyzer biocompatibility. What about the hemodialyzer flux? Actually, high flux dialyzers are preferred, as low flux hemodialyzer is associated with impaired platelet aggregation, and use of low flux dialyzers may further worsen platelet aggregation after dialysis, so high flux dialyzers are preferred. Infection can cause thrombocytopenia by inducing platelet activation. The pathogen itself can directly damage megakaryocytes or indirectly destroy platelets through immune response, and endotoxins can cause adhesion to platelet in microcirculation, and so relative thrombocytopenia. What about drug-induced thrombocytopenia? We have antibiotics, especially beta-lactam antibiotics, which can interfere with ADP receptors, aspirin, which can prolong bleeding time, and non-steroidal, which inhibit cyclooxygenase and alter platelet function. What about warfarin? Of course, it is a big issue, the issue of using anticoagulant in CKD, but just in brief, we can say that benefit of warfarin in patients with mild to moderate CKD, and I mean more than 30 ml per minute. its benefit to reduce stroke is firmly established. But their benefit in severe CKD and end stage are lacking, and should be careful when using these drugs with more labile INR, which is expected in CKD patients with vascular calcification, which can occur with them, and anticoagulation-related nephropathy, which is more common in CKD patients with high level of INR up to more than 3. Direct oral anticoagulant, like dabigatran, which is direct thrombin inhibitor, is contraindicated if creatinine clearance is less than 15, but can be given by a modified or half dose between 15 and 29. Also, rivaroxaban and edoxaban not recommended below 15 ml per minute, while apixaban can be used according to HA guidelines, CHEST guidelines, and KDIGO guidelines. Direct oral anticoagulant, the present evidence suggests that it can be used safely, and they are at least non-inferior or even superior to vitamin K antagonist, and KDIGO 2019 concluded that there is insufficient in patients with CKD, while in patients with CKD stage 5, patients with GFR less than 30 ml per minute, there is no RCT, randomized controlled trial, derived evidence that oral anticoagulant has a favorable benefit-risk ratio, and the KDIGO guidelines stated that there is insufficient high-quality evidence to recommend vitamin K antagonist for prevention of stroke in CKD stage 5 patients with AF, especially when balancing the risk-benefit ratio. And AHA guidelines focused a small recommendation for using oral anticoagulant with either warfarin or apixaban, but further studies are needed. In this meta-analysis, which studied apixaban and warfarin, it showed that use of apixaban was associated with lower risk of major bleeding compared with warfarin, and it was relatively effective with no excess risk of thromboembolic event. What about omega-3 fatty acid? Can it increase the risk of bleeding in patients with uremia? Theoretically, it is possible because omega-3 fatty acid can competitively replace omega-6 fatty acid in the cell membrane of many cells, including platelets, and the competition between them will cause decrease in thromboxane E2. This figure concludes what we say. The pathogenesis may include alteration in platelet synthesis itself, or dysfunctional platelet vessel wall interaction, anemia, reduced platelet aggregation, and drugs and dialysis itself. What about clinical picture? Uremic patients, of course, will have abnormal and high risk of bleeding, and in this study, CKD patients showed double the risk of intracerebral hemorrhage, and in another series of more than 11,000 adults, sites of bleeding was more common in lower GIT tract. What about lab finding? In this systematic review and meta-analysis, platelet count, 70% of the studies included in this systematic review and meta-analysis reported that platelet count was comparable to that of healthy control, and 25 showed reduction. Mean platelet volume, 50% of the studies reported it wasn't different to that of healthy platelets, whereas either observed increase or decrease. Platelet receptor expression of phosphorylated factor, fibrinogen, and P-cell-lectin were reported to be comparable with healthy control, while glycoprotein receptors was reduced. Bleeding time, most of the studies showed prolongation of bleeding time, and half of the studies showed decrease in platelet aggregation. There was also decrease in the level of serotonin, ADP, thromboxane E2, and decrease in platelet adhesion. What about management? We can manage bleeding by erythropoietin, desmopressin, cryoprecipitate, estrogen, or dialysis. At first, erythropoietin, which improve anemia, can improve bleeding by inducing erythropoiesis and increasing hematocrit and RBCs, which displace platelet closer to the vascular endothelium, as we discussed in the pathogenesis. It increased number of reticulated platelets, increased platelet aggregation, and it enhances the response of platelet to activating stimuli. And as we said before, RBCs act as a scavenger for nitric oxide. So high levels of RBCs after improving of anemia will decrease the level of nitric oxide, and so decrease cyclic GMP and improve platelet activation. Erythropoietin, its beneficial effect on platelets can occur as soon as 7 days after initiation of treatment, And our goal is to achieve a hematocrit level more than 30% to decrease bleeding time. And it can take up to 9 weeks in uremic patients to improve the hematocrit. What about desmopressin? It is a synthetic analog of vasopressin which activates only V2 receptors. It increases the level of cyclic AMP and so will induce exocytosis of full brand factor from its storage site in the endothelial cells, together with factor 8. It's given by a dose of 0.3 to 0.4 mic per kg. It can also be given either intranasal, IV, or sub-Q, and the IV route is the preferred type when treating acute, is the preferred procedure, or is preferred when treating acute bleeding episodes. The peak effect of after IV infusion occurs within 30 to 60 minutes, and the peak effect can occur after intranasal or subcutaneous after 60 to 90 minutes. We should be careful as the dose can be repeated every 24 hours, but shouldn't be administered for more than 3 days. We should be careful of desmopressin adverse effect. It has a vasodilator property, so causing facial flushing and tachycardia. It is an antidiuretic agent, so it can cause hyponatremia. There was a small series or rare but serious side effect, including arterial thrombotic events. Patients with TTP shouldn't receive this drug because further release of large fulfillment factor molecules into the plasma is thought to add more fuel to the ongoing thrombotic event in these patients. And we should avoid or be careful when using this drug in cardiovascular disease patients or pregnant women. In this study, which they used desmopressin for prevention of bleeding in percutaneous kidney biopsy, and they followed its side effect hyponatremia. 40% of biopsies which was done showed hyponatremia. 40% of the patients who had kidney biopsy showed hyponatremia. Of them, only 7% showed severe hyponatremia with nadir serum sodium level of 122 millimole per liter. And the risk factors for severe hyponatremia were the greater renal impairment, lower pre-biopsy serum sodium level, and higher doses of desmopressin. What about cryoprecipitate? Fibrinogen is the first coagulation factor to fall to critical levels during hemorrhage, and evidence suggests that fibrinogen supplementation can restore hemostasis. We have 3 options for fibrinogen supplementation. Fresh frozen plasma. It has lower fibrinogen content and it is stored at -13, so it may not be immediately available. Fibrinogen concentrate. A recent review identified 6 randomized controlled trials suggested that evidence supporting its use is weak and further data are needed. And cryoprecipitate, which is rich in factor 8, fulfillment factor, beside fibrinogen, and has high fibrinogen content. Cryoprecipitate acts by increasing clotting factors in patient plasma. Dosing is 10 bags of prepared cryoprecipitate given IV over 30 minutes. It has its beneficial effect within first 4 or 12 hours, but we be careful of its side effects and disadvantages of risk of transmission of infection, allergic reactions, and anaphylaxis. So the desmopressin should be the first-line therapy, shouldn't be repeated if bleeding is not controlled by the initial dose. If it is not controlled by the initial dose, then we can search for other alternative like cryoprecipitate or estrogen, as we will discuss. Cryoprecipitate is of benefit in cases of active bleeding and in cases who are in need of urgent surgeries. Those who have received 1 dose of desmopressin but haven't achieved hemostasis, they can use cryoprecipitate after it. We should assess the vascular volume, the volume of the patient, because of fear of volume overload before administration of cryoprecipitate. And it is thought that desmopressin and the cryoprecipitate together could be given in combination with additive benefits. Estrogen, it provides more chronic control of bleeding. Its mechanism of action is unknown, but it is thought that it may decrease the level of L-arginine and so decrease nitric oxide and decrease cyclic GMP, so cause platelet activation. It's given either by IV route for 5 days, can be given orally or transdermal, And the IV route is the best have been best studied and is preferred. Its onset of action can be on the first day, with peak action within 5 to 7 days, and duration of action can reach to up to 1 week or more after the therapy has been discontinued. The effect of estrogen is dose dependent, as its beneficial effect is not seen at doses of 0.3 milligram per kg, so the preferred dose is starting from 0.6, and its long-term use is limited by its side effects. Here we come to a question: can estrogen be administered to male uremic patients with active bleeding? The answer is yes, but most of the studies in this setting have been of limited duration, up to 5 days. The long-term adverse effects in males remain unknown, and administration of this hormone should be limited to 5 days and not more than 5 days. What about dialysis? Dialysis can correct bleeding time in about 2/3 of uremic patients, and some studies support a target creatinine less than 6 milligram per deciliter to maintain normal platelet function. We should optimize dialysis regimen and treat anemia. Daily and long-term dialysis may be of benefit. And regarding anticoagulation, we can use a modified regimen for high-risk patients for bleeding, like no heparin method using isotonic saline flushes. Minimum dose heparin involves bolus of 500 units of heparin every 30 minutes to keep target ABTT, or using a heparinized solution rinse, which is flushed through the hemodialysis circuit prior to patient arrival, then rinsed out by isotonic saline before connecting the patient to the machine. Regarding heparin-bonded dialyzer, some studies showed increased incidence of membrane clotting. Regional heparinization with protamine reversal is abandoned because of rebound bleeding, because 2 to 4 hours after the end of dialysis, because free heparin is released from protamine heparin complex back into the general circulation, causing rebound bleeding. Regional citrate anticoagulation showed reduced incidence of bleeding when compared with standard heparin protocols, but we should be careful of its side effects like hypocalcemia, hypernatremia, metabolic alkalosis, and of its toxicity with increasing metabolic acidosis or decreased ionized calcium or high total to ionized calcium more than 2.5. Prostacyclin is a serine protease, which is a serine protease inhibitor, which is given by infusion, and it has been limited by hypotension. It is present mainly in Japan and Korea, and its main advantage of this drug is that no further titration is needed once the goal of ABTT is met. What about anticoagulation in CRRT? Actually, I'm sorry, I don't know if you can see this algorithm, but anyway, in the left side, KDIGO guidelines in 2012 stated that we can use weak protocol without anticoagulation in CRRT patients who have contraindication to using citrate, like hepatic patients or hypotensive patients, or those with increased risk of bleeding. We can proceed without anticoagulation. This was in 2012, but in this systematic review and meta-analysis, which was published last year, they compared between anticoagulation-free versus regional citrate anticoagulation, and the result was that using regional citrate anticoagulation had this group had a longer filter lifespan, less filter clotting, and they were superior in azotemic control and uremic control, with no significant difference regarding bleeding and transfusion requirement. And they concluded that the optimal choice for anticoagulation strategy in high-risk patients could be regional citrate anticoagulation under close monitoring. What about Egyptian hemodialysis guidelines? Egyptian guidelines for hemodialysis stated that patients with impaired coagulation may not benefit from additional anticoagulation for renal replacement therapy. And there is no specific cutoff points for platelet count or INR that would indicate the possibility to perform renal replacement therapy without anticoagulation. And patient receiving systemic anticoagulation, we can proceed with them without additional anticoagulation during the dialysis session. But be careful, you should assess your patient that will have this anticoagulation-free strategy you should assure good functioning vascular access. You should reduce the blood viscosity by frequent saline flushes. Pre-dilution method is preferred with high blood flow rates. Diffusive treatment is preferred. You should reduce blood-air contact in public trap, and you should assure prompt reaction to alarms. Also, in Egyptian guidelines, they suggested using unfractionated heparin instead of low molecular heparin in patients with severe renal insufficiency less than 30 ml per minute. And citrate shouldn't be used in cases of shock or severe renal failure. And we should avoid regional heparinization during CRRT patients because of the risk of rebound effect, as we discussed, and side effects which are associated with heparin, mainly HIT, and protamine sulfate, mainly anaphylaxis. So to conclude, uremic, if I have a uremic bleeding patient and this patient is hemodynamically stable, I'll proceed to desmopressin plus or minus cryoprecipitate. If this patient is hemodynamically unstable, so if he can tolerate extra fluid, I'll give him whole blood and correct anemia. If I didn't get a benefit, I'll use desmopressin plus or minus cryoprecipitate. If I didn't get a benefit, I'll use estrogen. And at the end, if I didn't get a benefit, I'll assess him for dialysis. If I have a patient who have an urgent surgery, I'll start by desmopressin. If there is no urgent surgery, and the patient can still wait for another 2 weeks, we can use estrogen for more chronic control of bleeding. And at the end, we will assess him also for dialysis. What about some drugs like aminocaproic acid and tranexamic acid? They are antifibrinolytic agents which act by blocking binding of plasmine to fibrinogen. It has been shown to prevent bleeding and decrease blood loss and use of RBCs, and they can be given either by IV route or orally. And this study crashed to a trial which evaluated adult traumatic patients. It showed a reduction in mortality with early use of tranexamic acid less than 3 hours, as it reduced significant hemorrhage. And in 2019 crash 3 trial, which assessed total brain injury, it showed also beneficial effect of tranexamic acid in reducing head injury related death if it used within 3 hours. We should be careful of its side effect. In cases of urethral hemorrhage, it can cause obstruction. In cases of DIC, the use of antifibrinolytic agent may induce severe thrombosis, and long-term use of aminocaproic acid may cause generalized myopathy. What about renal clotho? In this recent study, which was published just 3 months ago, clotho is a phosphatoryc protein which is decreased in CKD patients. It has antioxidant effect, and it has multiple effects on extrarenal cells. This study showed or revealed a causal relationship between renal clotho deficiency and platelet count decrease in advanced CKD, which may offer a promising therapy choice in the future. Thank you.
Thank you, Dr. Moatasem, for this highly illustrative explanation of the bleeding tendency in uremic patient. You have illustrated the types, the causes, the pathogenesis, and of different causes, and finally the treatment, and you have addressed many lines of treatment. Really, what's striking in your lecture is that you give a special attention to the side effects of uncommonly used drugs that for this commonly met complication in practice, and also your final algorithm in dealing with this complication in different situations and in a step ladder fashion, step by step, how to deal with, how to manage, and even in cases of surgery that I really was waiting for this point, and I am really happy that you addressed in your lecture. Also the methods of renal replacement therapy, different methods, including even CRRT, you have illustrated in your talk in a very elegant and comprehensive way, and thank you very much.
Thank you.
We have many questions in the chat, and Professor Saeed Khamis wants to comment, but before let me start by one of the comments in the chat. I think it is directed to me about that from Dr. Abdullah Muhammad, that the only potential cure for uremic neuropathy is renal transplantation. Totally agree with you, Dr. Abdullah. But I was asking Professor Nashwa about some real case scenario that I have met in practice, and I am searching for an explanation. We may have a theoretical explanation for that, but totally agree with you that is the only potential cure is renal transplantation. Professor Saeed Khamis.
Yes, Professor Yasser.
You have a comment on this lecture, I think.
Thank you, Professor Yasser. Thank you, Professor Nashwa and Professor Moatasem, for this elegant two presentations. Just one comment regarding the presentation of Professor Nashwa. There are some rare types of neuropathy in our CKD patients, especially in dialysis patients. What's called ischemic monomelic neuropathy in the patient with AV fistula. This ischemic monomelic neuropathy is due to arterial occlusion by mistake of this AV fistula. I mean, while creation of this AV fistula, and this can occur even after 1 hour from the creation of a fistula. And this usually presented with motor and sensory affection, and it necessitates closure of the AV fistula, one of the causes of to close the AV fistula as a treatment. Second one, regarding Professor Moatasem, regarding uremic bleeding. If you use what's called saline flushing, every 1 hour, you use 100 milliliter or 50 milliliter, and you consider this in the ultrafiltration. It is a good way. And there is another way is to use continuous infusion of IV saline by drip. It will be more effective in small study I saw in the literature, rather than the pulse therapy of this saline. Second point is, it seems to be a delicate question, but we face it every now and then daily in our practice. If you have a patient, Professor Moatasem, on NOAC, like apixaban, for sure, that's the one allowed in our dialysis patient, and or even warfarin, and they will come to dialysis. There is a misconception that we shall do heparin-free dialysis for him immediately. Do you agree for this, or we should try make trial and error, use minimum dose heparin, saline flushing, and if there is no response, we can increase the dose of heparin a little bit, and so on. Thank you so much for both professors, and have a nice day, inshallah.
Thank you, Dr. Saeed. Thank you so much, Dr. Saeed, for your comment. Actually, the Egyptian guidelines in 2019 stated that patients who are maintained on anticoagulation can proceed or can get benefit without adding other anticoagulation during the procedure of hemodialysis. So I think it can be a trial and error, as you said.
Okay, thank you, sir.
Thank you.
Thank you, Dr.
Dr.
Saeed.
Nashwa?
Thank you. Dr. Yasser.
Do you have a comment on Professor Saeed?
Thank you, Dr. Saeed. The ischemic mononeuropathy secondary to AV fistula, one of the neuropathies which occur, but it is different from the uremic neuropathy at the cause and the site. The site of the affection, the uremic neuropathy mostly affecting the lower limb at first, but the ischemic neuropathy secondary to the AV fistula affecting the site of the AV fistula, but it is a very important issue. We can illustrate it, and يعني من الحاجات اللي لازم ناخد بالنا منها طبعا اللي هو الاسكيميك neuropathy secondary للAV fistula.
Thank you, Professor.
Thank you, Dr.
Thank you, Professor Said. Thank you.
On the chat, we have start of our first question from Dr. Abdelhadi Ramadan about the efficiency of Tegretol and gabapentin, and is also the same question by Dr. Abdullah Muhammad about efficacy of gabapentin in uremic neuropathy. Professor Nashwa.
The usage of the gabapentin, there is a study done to use the gabapentin in the uremic neuropathy, but it can use as adjuvant therapy, not for treatment, due to its action in remyelination of the nerve, so it is reduce the neuropathic pain, but not for definite treatment. Just it is used as adjuvant therapy, but there is studies done on the gabapentin usage for uremic neuropathy.
Only a symptomatic treatment, huh? Not.
Yes.
Not definitely.
It is. It can be used as a symptomatic treatment to relieve the pain, neuropathic pain.
Dr. Abdelazim asks about, can it present as acute way bilateral lower limb weakness in cases of end-stage kidney disease, creatinine 8 milligrams and urea of 200? In my hospital, the patient with Guillain-Barré with AKI, and they already do plasma exchange. Is there any link between this acute form and kidney, or just a coincidence of both two conditions?
In case of Guillain-Barré neuropathy, it has a protocol of treatment different from the uremic neuropathy.
His question is that he found a case of Guillain-Barré acute polyneuropathy and AKI at the same time. Did you find in your research and in your journey through this topic some case reports or some explanation to something like this, or it was just coincidence of two conditions together in the ICU, and we have no theoretical basis for this?
Exactly, I don't found studies on the Guillain-Barré with acute kidney injury.
Okay.
But it can occur, but the first line of treatment will we treat the Guillain-Barré as he has a specific protocol of treatment.
Okay, of course, plasma exchange.
Yes, plasma exchange and the use of steroid. Yes,
grade A in plasma exchange. My friend Moatasem, you have many fans here. Dr. Muhammad Al-Saftawi, Dr. Muhammad Tahir, Dr. Ahmed Hassan, and even Dr. Muhammad Abdelbari, all of those. Thank you for this, your great lecture. And Dr. Muhammad Abdelbari, before leaving today, thanks both speakers, Dr. Nashwa and Dr. Moatasem, for those great lectures.
Thank you.
Thank you.
Dr. Abdelhamid Hamdi asking about furosemide causing thiamine deficiency in CKD patients, and the need to check and replace. Do you find anything for thiamine deficiency with the use of diuretics, furosemide in CKD patients? Dr. Nashwa, question is to you.
نعم يا دكتور. Another
about thiamine deficiency with the use of diuretics, thiamine deficiency with the use of furosemide. Any comment for this?
Yes, there is thiamine deficiency can occur as a factor for uremic neuropathy. Thiamine deficiency, one of the factors can increase the neuropathy. Usage of the diuretics induce uremic neuropathy. There is no studies for this issue يعني. لكن هو الدايوريتكس يعني اليوسج بتاعها ليها برضو indication مع العيان السي كي دي. لكن هو الثيامين ليه رول ان هو الثيامين deficiency can occur uremic neuropathy.
Okay. A question from Dr. Abdel Hamid Hamdi, and it's really my question also. I have the same question. The overlap between diabetic and uremic neuropathy. We feel all that it is nearly the same picture and the same clinical presentation. And I think the investigation will find the same regarding nerve conduction. Do you have any comment of this to differentiate, or we should proceed in the same way for both and dialysis in cases of diabetes and stage renal disease?
The diabetic neuropathy and the uremic neuropathy, there is a big link between them. And the diabetic neuropathy, the most common presentation, sensory motor affection. And there is a study done on diabetic neuropathy and another group with uremic neuropathy and not diabetic. And there was significant variance ما بين الدايابيتك نيوروباثي واليوريميك نيوروباثي في السنسوري موتور. موستلي بتبقى افكتد مع الدايابيتك نيوروباثي، بتبقى ظاهره اكتر السنسوري موتور افكشن.
So yeah, diabetes have a motor part. I think it's a sensory. Do you mean that diabetes will have a motor combination?
لا الدايابيتك نيوروباثي اللي بيظهر سنسوري في الاول بيبقى mainly sensory. لكن لما بيبقى associated معاه uremic neuropathy بيبقى sensory motor.
Sensory بيبقى adding a motor part in nerve conduction.
Yes.
But usually clinically we found the sensory part.
Yes.
Professor ElSayed wants to comment.
Yes, please. Thank you again, Moatasem. I already agreed on Nashwa response for the neuropathy, and all the questions are of value. And thanks again to Moatasem. It was very informative.
Thank you.
Just to highlight two points of our clinical practice. One is, if your patient needs more than 2 units PET, red blood cells, you have to be sure that number one, there is no dilutional coagulopathy. So every 2 units, it's better to give 1 fresh frozen plasma if no contraindication, because the patient usually has dilutional coagulopathy from repeated blood transfusion. Number 2, important to give blood transfusion, as you have excellently highlighted that in the Egyptian hemodialysis guidelines, that I'm proud to be an auditor in this one, is be aware that of blood transfusion should be very, very early at the dialysis start, because hyperkalemia is common with older blood more than 2 to 3 days. So if you are giving, and highlighted that in the guideline, give blood transfusion very, very, very early in the start of dialysis, not at the end of dialysis, for fear of hyperkalemia, and be aware of hypocalcemia from the citrate. So usually we recommend that giving IV calcium for patients needing more than 2 units blood for that. My second one is of other clinical value as well, is most common of patients with vascular access recirculation has frequent clotting, and the sequence is to give more heparin, and if you do so, you have clotting and bleeding. So be sure that patients, around 10 to 15% of patients, has significant recirculation, and if the patient has frequent dialyzer clotting, think about recirculation and fistula needle repositioning, so you don't need to give too much of heparin. If you are giving low molecular weight heparin, it's safer in bleeding tendency rather than low molecular weight, because heparin is a couple of hours duration of action, while low molecular weight heparin needs more than even 12 hours of bleeding. Third point, important, take care of patients with anemia that is not explained by GIT hemorrhage. So if your patient has frequent blood transfusion and maximize hypotherapy, rethink about, again, bleeding disorders from the GIT. And thank you again for all. I enjoyed really the talk today.
Thank you, Professor.
Thank you.
Thank you, Professor Hisham. Thank you so much.
Thank you.
Thank you.
Thank you, Professor Hisham.
Thank you, Professor
Thank you very
Yasser.
much.
Thank you, Professor Hisham. I totally agree with you that we should keep in mind the GIT bleeding, minimal GIT bleeding in cases of unexplained anemia, especially of decreasing hemoglobin with no other obvious cause, and maximum or optimum EPO and iron therapy. We should keep this in mind. And I think I have found some cases that improved with the use of some intensive courses of PPIs. I think no more questions. No more comments. Thank you, Professor Nashwa, for this highly elegant talk. Dr. Moatasem, thank you very much for your highly comprehensive talk. We really all enjoyed, and I think all our attending professors enjoyed this very specific session, and
this session of upcoming stars.
Yes, we have a very promising future in our speakers, in coming speakers in the ESNT, and we can expect coming very fruitful generations and very fruitful scientific meetings by growing of these highly intelligent, comprehensive, and very, very, very effective and professional generations. Thank you, and excuse me to close this session and announce about the coming session will be coming Wednesday in the same time. Inshallah, Professor ElSayed will speak about uremia in CKD and in kidney transplantation. Meet you in the same time, inshallah. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته.
ألف شكر.